So when I was graduating from college, I had two interests. I wanted to be both a country doctor, like Marcus Welby, and I also wanted to be a scientist. I wanted to be a scientist because I had developed an interest in biological networks, and it seemed like these things were impossible to reconcile. It turns out that you, as taxpayers, actually fund a program where 1,000 people in the country a year, approximately, are paid to do both, go to medical school and go to graduate school. But what I was really looking for is, how do you tie these things together to improve the health in our country? And what I found when I was in medical school is that whenever I talked about being a country doctor, people said, that's fantastic, you should go abroad. And they pointed to places like this lush valley in southern Uganda, Ruhira, where there's an immense need for health. And I was thrilled. I grew up in Kenya, and so it was kind of like going near home. And whenever I talked about research and networks and health systems, people were also thrilled. And in graduate school, I dived into the inset image here, a microscope, and I looked at biological systems from the inside. But whenever I asked or looked for ways that I could bring these things together to be a country doctor who worked on health systems in the United States, there was a tightness. There was a tightness in the conversations that I read in articles and magazines, on TV, with my parents in Indiana who ran a small business, and also with faculty that thought there were two perfectly good options, and this was a problem that would work itself out. This tightness seemed to stem from money. And whenever we spoke about it, it was either a lack of money, too much money, or misallocated money. So I went to speak to an economist. I met a remarkable man named Jeffrey Sachs at the Earth Institute, where I've been since. And without giving me an opinion about the economics, he said, we have to really understand the problem. And he said, why don't you go understand the problem? And so I went back out to places where I was either familiar with abroad or not familiar with, and started to look at it with the mind of coming back someday and working on this problem in this country. So when you look at a map of sub-Saharan Africa, these red zones here are distances, are the number of hours it takes to get to a city, a market, an industry, places where there's about 20,000 people. In these places, you're more likely to find hospitals and clinics. If you take a look at the big red spot on the top, that's the Sahara. So not that many people there. But if you take a look throughout sub-Saharan Africa, there's substantial red spots where there's a lot of people. If you actually look at the graph, even light green is 1 to 2 hours. And as a result, the way that we have to think about health systems in sub-Saharan Africa is completely inverted. We don't think about hospitals first, we think about households first. And you start with household as your center, community services around it, and then local and regional health systems. Coming back to the state that I've lived in for many years, New York, the red represents something different in this graph. The red represents where there are hospitals. And if you take a look down where we are, you can't even see Brooklyn. Brooklyn's covered by so many hospitals, and Manhattan and so forth. And the rest of the state, there's a smattering that seems to follow the lines of the interstates, much like you'd have the veins in a leaf. But as we know, even in hospitals in Manhattan or in New York City, all's not well. They're closing, they're collapsing, as we try to squeeze more and more people into these places. And when you look at the relative hinterlands of New York, where I also went to school for college, there's places that are relatively sparse, and we're still trying to shuttle them in to the hospitals, either in New York City or along the state. And so I thought about this process a bit with a lot of people that have also been thinking about this. And it seemed that there was a process that was common to both places. You start in the community, and the big decision when you're sick is to make a decision to seek care. If you're in a place like sub-Saharan Africa, you have many options. You have the formal health system, you have other people that provide health, and you have people that are less reputable and more reputable in your community. And even here in the US, when your child is sick, when somebody has a fever, when you're feeling ill yourself, you have to make a decision to seek care. So that's a big step. And then you have to identify and reach the medical facility. Most of the time here in the US, that's trivial. You go onto Google, you find it, you call somebody up, and then you get treated. And this side, on the right, is really where we excel. We identify and reach medical facilities well, and we treat well. We have some of the most advanced hospitals in the world, whereas in low resource settings, the communities that I've seen and worked with have really focused on the community itself, decision to seek care, and focusing back on the households. And it seemed to me that there was an opportunity to complement strengths, where instead of focusing on one side to the neglect of the other, or the other to the neglect of hospitals, there was actually an opportunity to do both. There are many people working on bringing hospitals and health systems to sub-Saharan Africa. But it seems to me that we really need to make a swap. So here's the swap. All over sub-Saharan Africa and other parts of the world, Latin America, China, India, sophisticated networks of communities, lay community members that have not been educated in healthcare are mobilizing. They're mobilizing not in just a grassroots fashion, but on very large scales. And with that comes a way of interacting in environments where technology is not always a given, where you don't always have roads, and you can't always communicate and have the information immediately. And yet, it's all that many people have. And so, we have an opportunity to look at some of these ways to spread out some of the burden on our hospitals and on our health systems, and looking back to communities and the networks that we form, whether we're at this conference or out in our neighborhoods. Just to drive home that this is not just about grassroots, which is critical to these interactions. This is a country of about 1 billion people, India. And across India, a remarkable program has been launched in the last few years. It's called the Asha Program, and it means hope. 600,000 lady health workers have been activated and deployed and empowered in communities to serve as activists for people's health. This doesn't equal community doctors, but it does mean that there's a linkage from households to health systems wherever they are. So how is it possible to coordinate 600,000 people, or in Ethiopia, 30,000 people, or in Nigeria or Ghana? How is it possible to coordinate these large groups of people when you have such thin amounts of resources? Part of the solution is in replicable innovations. This is an interaction where a community member is using a cell phone that prompts her through a scripted conversation to find out if the woman who's pregnant is at high risk. As she clicks in answers, yes or no, what the prompts that come up actually change, and helps guide everybody through this. The key is that the wisdom is in this interaction. The intelligence is in the people. The information is exchanging hands, but the knowledge remains and resides in the community. We've worked in the past few years on a remarkable collaboration across 10 countries in sub-Saharan Africa called the Millennium Villages. In this environment, we work with communities to figure out how is it exactly that people are able to coordinate with such few resources, and able to actually accelerate progress to making health possible. It starts with a household focus. It means going out from a health center to households Not necessarily fully paid doctors, but people who are from the community, who live there, and they can make a phone call, and they activate an entire system. There's national linkage. As people call in, use their cell phones to send structured SMS text messages, you can find out how many people are sick in an area, where they are, and how urgent it is. This gets bounced back down to local management that actually drive the decisions to what needs to be done with the best knowledge of how to actually meet these solutions. Now, this isn't all about technology, because this is fundamentally about people. This is also in southern Uganda. And you have people, health workers, lay people who are trained. They're locally based, men and women, all ages. They're nominated by their community. The programs to train them emphasize literacy and already very abundant numeracy, because many people have phones and an increasing number of people do. And it's about job creation, paying people the amount that is possible to be able to go out and actually do this work. And with 10 countries, there's immense variation in how this is done. So these are really people-driven systems. If you look on this side, you see that the issues that are dealt with in a lot of the world are the same as what we worry about now: nutrition, long-term care, populations. And the ways that it's done in communities sounds like a hospital or a corporation. People think about supply chains, organizational skills, and strategic planning. Now, there's an immense need for these skills to actually be inputted into the system, but it's moving that direction. We built an organization called Community Lab, which really emphasizes the fact that this is both grassroots efforts, but it required systematic efforts from national governments, from industry, from entrepreneurs. And our goal at Community Lab is to consolidate this information from all across the world, using people that have different skill sets to actually be able to transfer it into new places. And from my perspective, this is perfect timing. In the past 8 years in the United States, starting with George Bush and extending with Obama, the largest expansion of community health centers has taken place in this country. These community health centers have gone from serving 4 million people to 15 million people and beyond. They're engines of community. They're engines of local job creation, and they're critical places for people to get services that are closer to home. Think about the numbers. We have 300 million or so people in the US. If you take the same ratio as they do in India, we need about 300,000 health workers. That's half the number of people that were deployed in 2 years in India. If you think that's a lot, 15 times that number, 4.5 million, are public notaries in this country, people that have gotten training and are recognized by the government to be able to do a service. So it's not impossible by any means. And again, the timing really couldn't be perfect. We have these community health centers in our own cities, in our own boroughs, here in Brooklyn. Across Brooklyn, we have people like you in the audience. We have innovators, we have entrepreneurs, administrators, people with technical skills, and we have people that run businesses and have creative ideas. Go to your community health centers. You will find some of the most compassionate, creative people there that are not only willing, but want your participation, your support, and your collaboration. Again, when I look out and I see this divide, whether it's doing global health work or working in the US, it's really a false divide. A lot of the techniques that are taking place in low resource areas are the same that we need here in this country, whether it's in Brooklyn, parts of Manhattan, or in Indiana, where my parents are. And I've seen amply throughout the world the power of one of us to care for many. Thank you.